There are multiple ways that I hope in my lifetime we will optimize treatment for PTCL. Some of that will be by the incorporation of novel agents potentially to CHOP-based therapy. So there's studies. Unfortunately, some of the studies that have been done so far didn't meet that mark. And it's possible that if you refine the study population, you would find that adding X to CHOP benefit some group of patients, and you can power a study specifically for that group of patients and improve outcomes for each histology at a time. Some of those studies are ongoing currently, so I'm fortunate to help lead the U.S. intergroup study looking at the addition of either Azacitidine or Duvelisib to CHOP-based therapy, with CHOP being the backbone therapy for those who are over 60 and CHOEP being the backbone for those who are under 60, where patients will be stratified based on TFH phenotype. This is a phase 2 study, not a phase 3 study, though. And so we'll see how much we'll find out what the results are, and then hopefully help the community to interpret those results. Similarly, there are markers of dynamic response. So we've seen this in diffuse large B-cell lymphoma. We're looking at interim PET is prognostic, or looking at minimal residual disease in the blood is highly prognostic. And those studies are currently ongoing in peripheral T-cell lymphoma. So there's an analysis from Echelon 2 showing that interim PET after 4 cycles remains prognostic in patients with peripheral T-cell lymphoma, that recapitulates work that was done by many people, including myself, retrospectively looking at patients treated with CHOP-based therapy with the intent to transplant, suggesting that interim PET is also prognostic in that population. So I think hopefully in the future, we'll be able to combine more sophisticated imaging modalities like metabolic tumor volume at baseline with PET, interim PET, to help identify who's likely to be cured or not likely to be cured with frontline therapy, even before they complete 6 cycles of therapy. There's work being done by a number of labs, including the Elizadeh lab, looking at minimal residual disease in the blood in peripheral T-cell lymphoma and identifying who still has residual disease and is unlikely to be cured after a couple cycles of therapy. And some on the counter, also looking at who has no minimal residual disease in the blood and is likely to be cured with frontline therapy. We hope that, I hope with that sort of testing, we'll be able again to pivot people unlikely to be cured to other therapy that might lead them to bridging to an allogeneic transplant, which can be curative in that population. And on the counter, we standardly do an auto transplant in first remission, or many of us do an auto transplant in first remission in this patient population. And we might learn that benefits some patients more than others, and we might be able to use these types of techniques to help minimize toxicity that patients face, or really try to personalize who gets those sorts of interventions based on their risk factors.